Hello, Dr. Slip, classmates, adjudicators, and my opponent. My name is Mariana, and today I oppose the motion that provincial regulatory bodies for health professionals be replaced by national bodies for the registration of regulated providers. Before I begin, I would like to acknowledge that Athabasca University respectfully recognizes that we live and work on the traditional lands of the Indigenous peoples of Canada, including First Nations, Inuit, and Métis peoples. We honor their ancestry, heritage, and gifts, and give thanks for their enduring contributions. I would like to note that the stance I am presenting today has been assigned and may not necessarily reflect my personal position on the motion. Today I will demonstrate that provincial regulation of health professionals is a constitutional necessity and a key safeguard for public protection and equity. I will do this by outlining 5 main arguments. First, the role of regulatory colleges in protecting the public. Second, the constitutional framework governing professional regulation. I will then address equity and local responsiveness, the evidence for national replacement, the risks large regulatory transitions pose to public protection, and finally, the case for incremental reform. Before we continue, it is important to consider why this debate matters. This debate matters because the regulation of health professionals exists first and foremost to protect the public and to ensure patient safety. It's also about equity. Healthcare needs vary widely across Canada, and regulation must stay aligned with local delivery models, especially in rural, northern, and underserved communities. Accountability and system stability are just as important. Public trust depends on clear authority and timely enforcement, while large-scale regulatory changes carry well-documented transition risks. Finally, many goals often cited to justify national replacement, like workforce mobility, are already being addressed through existing reforms such as the Canadian Free Trade Agreement. In short, this debate is about protecting patients, preserving equity, and ensuring accountability, not simply reorganizing regulation. The first core argument against national replacement relates to the role provincial regulatory colleges play in protecting the public. To assess whether provincial regulators should be replaced, we first need to understand what they do. In Canada, regulatory colleges do far more than just register professionals. They set standards of practice, investigate complaints, and enforce accountability when those standards are not met. These functions are rooted in provincial legislation and are aligned with local healthcare systems. Regulatory colleges exist for one reason: public protection. Any proposal to replace provincial regulators must therefore show how these core functions would be preserved or strengthened, not simply centralized. And because these functions involve legal authority and enforcement power, who holds that authority matters. That brings us to the constitutional framework. The next core argument against national replacement is that it conflicts with Canada's constitutional framework for health professional regulation. Under the Constitution Act 1867, professional regulation falls under provincial jurisdiction. Courts have consistently interpreted provincial authority over property and civil rights to include professional regulation. As a result, provinces are legally responsible for regulating health professionals, authority that cannot be displaced by a national regulator. This matters because professional regulation is not separate from healthcare delivery. It is one of the ways provinces ensure care is safe, accountable, and aligned with local health systems, including funding models and scopes of practice. Because this authority is constitutionally provincial, replacing provincial regulators with a national body would actually not eliminate provincial involvement. Provinces would still be responsible for enforcement, complaints, discipline, and alignment with their own health system frameworks. So rather than streamlining regulation, national replacement would introduce overlapping authority, and increased complexity, blurring accountability and increasing patient safety risk. So you can add a national layer, but you can't remove the provincial one. And even if national replacement were constitutionally possible, it still fails on equity. National uniformity is not the same as equitable care. A central part of our argument is health equity. The realities of practice in downtown Toronto differ significantly from those in rural Nova Scotia, northern Manitoba, or fly-in communities in Nunavut. Equity requires regulation that can respond to these differences, not ignore them. A one-size-fits-all model fails to reflect them. Provincial regulatory bodies tailor standards of practice, scopes of practice, and oversight to the population they serve. These regulatory frameworks are embedded in provincial legislation and aligned with local workforce realities and service delivery models. By contrast, centralizing regulation at the national level prioritizes uniformity. While uniform standards may appear equitable, they often fail to account for regional, cultural, and demographic differences, particularly in Indigenous, northern, and rural communities. Effective regulation also depends on proximity. Provincial regulators are closer, operationally and legislatively, to practice environments, allowing oversight to remain timely and responsive. In short, replacing provincial regulators with a national body would not enhance equity. It would reduce the local responsiveness that equitable, context-sensitive care depends on. Equity is achieved through regulation that responds to local realities. These concerns leads to the next question. Is national regulatory replacement supported by evidence, and does it deliver better outcomes in practice? My next argument concerns evidence, or more accurately, the absence of evidence supporting national replacement. There is no clear evidence that replacing provincial regulators with a national body improves patient safety, quality, or system responsiveness. Evaluations of Australia's national scheme, APRA, have identified significant shortcomings, including governance complexity, uneven performance, and persistent stakeholder dissatisfaction. Centralization has not resolved regulatory challenges. Instead, it has introduced new ones, requiring ongoing correction, without actually demonstrating improvements in patient safety, quality, or accountability. A more recent independent review of the same national scheme reinforces this conclusion. Despite its original intent, the system has struggled to deliver its full potential, citing a focus on internal processes rather than outcomes, fragmented accountability, slow responsiveness to emerging risks, and weak evidence-based decision-making. When a system-wide replacement is proposed in the absence of evidence demonstrating improved outcomes, the risks associated with the transition itself move to the forefront. Which brings me to the next argument, transition risk. Large regulatory transitions carry significant operational and public safety risks. They simultaneously affect registration, workforce availability, complaints handling, and patient access to care. Evidence from Australia's transition to national registration shows that regulatory realignment caused service disruptions. Qualified practitioners experienced delays or were unintentionally deregistered, interrupting access to care, particularly in rural and underserved communities. In short, national replacement creates a period of regulatory instability where accountability is blurred and patient safety is exposed. In regulation, how change happens matters. This brings me to my final argument. Reform does not require replacement. Incremental reform is safer and more effective. Canada already has evidence that targeted incremental reform works. Workforce mobility, often cited to justify national replacement, has already been strengthened through existing mechanisms. Under the Canadian Free Trade Agreement, regulated professionals are entitled to, as of right, credential recognition across provinces. Harmonized standards and shared pan-Canadian tools, including national entry to practice exams and competency frameworks, are reducing barriers while preserving provincial accountability and public protection. Health professions discipline tribunals are another important example of incremental reform, improving consistency, transparency, and procedural fairness in disciplinary processes while preserving provincial regulatory authority. These gains have been achieved without dismantling provincial regulatory authority or introducing system-wide risk. Simply put, we do not need to replace provincial regulation to improve it. What we need are reforms that protect the public without introducing unnecessary risk. To conclude, health professional regulation exists for one reason: public safety. Replacing provincial health professional regulators with a national body is not supported by the Constitution or by evidence of improved outcomes. It offers no demonstrated benefit and instead introduces governance complexity and transition risk, while deepening inequities for already marginalized communities by centralizing authority away from local contexts. Evidence-based incremental reform is already working. Labor mobility and mutual recognition have advanced without dismantling systems designed to safeguard the public. For these reasons, provincial regulatory bodies should not be replaced. Patients depend on regulatory stability. Reform should strengthen what works, not destabilize the systems designed to protect them. Thank you.